Okay. We're now going to talk about the role of nurse support with Gill Gordon and Suzie Thompson. Gill's from QENDO and Suzie's from True, the duo, the dynamic duo. We have Suzie, who is an experienced sexual and reproductive health nurse. Just let that helicopter go past. Hope they're okay. Not a good sign. And so Suzie has over 8 years experience spanning from clinical services and clinical education, based in Brizzy with True, also travels to rural and regional areas to deliver reproductive health care, specifically trained in IUD and implant insertion and removal, and has a postgraduate qualification in sexual and reproductive health and emergency medicine. Handing over to Suzie. Thank you so much.
Just using this one. Excellent. Thank you very much. And a quick shout out to all my True colleagues here in the room and around the state hosting a great event, and great to be here representing nurses and chatting a bit about the role of nurses within endocare. So this is all information that we're all well aware of. We know the stats. We know that it's a chronic, complex, often relapsing condition. And as Hilary said, we know it has significant impact on quality of life and function. So we know it's a challenging condition, but it's also challenging to our system, to our healthcare system. So the current reality of what our patients are experiencing is fragmented care pathways, often limited continuity of care despite best efforts of very busy healthcare professionals in every element of our system. And therefore, often our patients are left self-navigating through these complex systems. We know what works. We know the ideal team has a fabulous GP who has lots of time, easy to get into appointments, really engaged and interested in endometriosis and pelvic pain. We've got our gynecologist who is also an endometriosis specialist, our pain specialist, our pelvic health physio, which I often will put to the top because I try to tell patients how that's sort of like one of the number one most important things that we can do, and referral pathways we can have. Our psychologists, certainly on here, as well as our dietitians, our acupuncturists, our naturopath, and of course our nurses, but we'll get to that. And realistically, these services often exist in silos. There's very little central coordination. Although we are starting to see it, I'm so excited to say, within our funded endo and pelvic pain clinics around the country. So often patients are left acting as their own care coordinator. So what's the missing link? I may be biased, but it's nurses working to do their full scope of practice. So advanced practice nurses, nurse practitioners, delivering specialty clinical care. So with special interest in this area where it's often what they do day in, day out, can deliver a high level of clinical care, coordination, navigation. Anyone who's worked with a nurse in the healthcare system knows that they know all the ins and outs and all the roundabouts and navigating through the system, and helping to facilitate that continuity of care, helping to deliver that continuity of care. The value is not just in high quality clinical care, but it's the integration of that care across providers, across settings, and across time. So bringing the healthcare team together for the patient. I often think of endometriosis care as a team sport, and the patients are MVP, and it takes that team around the patient to support them to bring the best out in them. A couple of updates around that have happened in the nurse practitioner space within the last few years in regards to MBS reform that have really meant that we are able to take more of a financially viable role within the multidisciplinary care team for patients across many facets, but certainly in context of endometriosis and pelvic pain care. So in July 2024, the rebates were increased across consultations, both face-to-face and telehealth. Of course, they have not increased enough, but it was a good step forward. In November 2024, we got the additional item number for consults over 60 minutes, which, as many of you will know, a lot of our clients with endo and pelvic pain often do require. And we were able to start ordering pelvic ultrasounds, and the patient get a rebate back through MBS. Then, most excitedly, in November last year, our first real procedural numbers for nurse practitioners came along, matching those for our medical officers for LARC, so our Mirena insertions and Implanon insertions removals, and now the patient will access the same rebate cost. And as of just this month, the MBS rebate also applies for the complex gynae ultrasound or the endo scan if a nurse practitioner orders it as well. So really what this boils down to is that for the patient, it doesn't matter, who is ordering that test or who is doing that Mirena insertion, they're going to get the same rebate back for the same service. I couldn't come up with a great segue to this, but it's a little bit of a soapbox for me. So I thought I would take my opportunity to share something I'm very passionate about. And this really comes from, nursing ultimately is about patient advocacy. That's what our role, that's what the foundation of our role is. And, this is a bit about advocacy in practice. I see a lot of patients day in, day out. Here in Brisbane, one patient said to us, we're like IUDs are us in our Brisbane clinic. We do them all day, every day. And so I see a lot of patients before their IUDs for suitability assessment. And the one question or topic when I say, before we launch into it, is there anything you've come with today? Any burning questions, anything you're worried about? And it's always about the pain of an IUD insertion. These images are a quick Google. This is what our patients are seeing. If they've been recommended a Mirena for their heavy menstrual bleeding, for their, severe dysmenorrhea, they're going, okay, let's look into it. This is what they're seeing. This is what they want to talk about. The picture of the Mirena box, if anyone has seen it, it is large. And I will always give patients a heads up when I give them their script. I say the box is large, but the device is small, and I always have one there to show them, because it really is off-putting when they see that. When you see images like this, I've had patients say to me, can you just show me that tenaculum, because that looks really scary. They're seeing these images, they're coming in. What I am most passionate about around trying to work with patients about pain or potential pain or perceived pain with IUD insertion is all the women who aren't even getting to us because they're not even going there. They don't want to know about it because they've Googled it, and they are not coming to see us for a Mirena. But Mirena can change their life. And so it's about changing the experience, and then they're going to tell their sisters and their friends about the great experience that they had. When they're online, this is the stuff where there's more and more studies come through about the impact of social media on around IUD insertion. And we know, it is not sexy to share great stories like, oh, I had a Mirena and it was fine, I barely felt it. It is so much bang for buck, so many more clicks if you've got a nice, dramatic, juicy story to share. So again, women are getting more and more put off. So coming from an emergency background where I felt we gave a lot more pain relief for a lot less things, I knew that we had Penthrox around and love a bit of happy gas, wanted to see how we could use it more freely for our IUD insertion patients. So we did. I've cut through a whole lot of information just to get to the point of we now talk about it quite openly, offer it. When I looked at some information of mine across an 18-month period of 130 IUD insertions I did, 44 women chose Penthrox. So 1 in 3 women chose Penthrox. Certainly a fairly high proportion were younger Nullet patients, but interestingly, there were plenty of patients within that who have had vaginal deliveries before, who've had IUD insertions before, and particularly had traumatic experiences and were put off about the changeover. And 98% satisfaction. I had an IUD insertion clinic today and had a young 17-year-old who I suspect may have endo, who wanted a Mirena, was loaded up on the Penthrox and giggled through her Mirena insertion. I mean, is that not what we should be aiming for? So some final reflections to leave you with. How can you help build a more seamless and integrated pathway for your patients to travel through their endometriosis journey? Does your team and your network include a nurse navigator or a nurse practitioner? If not, why not? I may hear you say finances, there's not enough money to support. I agree. But we need to join together as one healthcare team. This isn't about professional turf wars or who's doing what. It's about all of us working to our full scope of practice together as a united team, whether that's political advocacy, getting our patients on board. Because when patient advocacy guides care, we build a true patient-centered model that can stand against system complexity. Thank you.
Amazing. I think we've seen that in the endometriosis space, that last point around when we come together, we can build systems and redesign systems. I'm excited to share another nurse this evening and acknowledging we haven't had dietetics here tonight or so many other things we didn't have. We'll hopefully have to do a phase 2 perhaps. But nurse Gill is a much loved person at QENDO. She's the one taking a lot of the very emotional calls. Gill and I met in the toilet line after a nurse education day where the best friendships are created, in my opinion. And we just connected and how it's helped to build. But Gill has lived experience of endo, chronic pain and other areas, but also has many, many, many years as an IVF nurse. So crosses over to many different areas. So bringing over what the nurse support can provide in terms of practical skills, please welcome Gill.
Thanks, Jess. Before I get started on what the nurse support can provide, I just wanted to touch on the multidisciplinary program that we have put together with QENDO. We are funded by the Brisbane South PHN, and we've brought together the dietitian, the pelvic health physiotherapist, a counsellor, led by myself, the nurse, and the patients can be referred in, they can self-refer or they can be referred in by their GP. They don't have to have a diagnosis. It can be suspected, they can have symptoms, or they can be diagnosed with endo, adeno, PCOS, infertility, persistent chronic pelvic pain, and they get referred into us. We triage them, I meet with them, I hold that space, they debrief with me the amount of tears that are shared through that appointment through myself and with my patients. I see them, I hear them, I validate them, they tell their story, and then we create a really tailored plan put together to provide the support that they need for where they're at. It's a brilliant service because it's also telehealth. So one of the few good things that have come from COVID is that we can see that healthcare can be provided via telephone, video, email, text, and we meet them where they're at. So the number of appointments that I've had with patients lying in their beds, now those appointments probably would have been FTAs because they physically couldn't have gotten out of their beds and caught the bus or got in the car or physically even gotten dressed to attend that appointment. So I meet them where we're at. I've had appointments with people in the park, in their lunch breaks, in a car. And I'm like, oh, we need to get this done because it's boiling hot for you. So we're meeting them where they're at. And so providing that space, seeing them. Then I give them the guidance to navigate because, as we all know, it's such a complex space, and understanding it. Someone described it to me as it's like having a full-time job. And so helping them navigate all of that. Also bringing in strategies to support their partners and parents. We've had mums that have come to us in desperate need of help. Where do I go? What do I do for my daughter? She doesn't want to attend these appointments herself. So I'm coming on behalf of her. Husbands, I've had appointments with husbands and partners sitting next to their wives or their girlfriends. We have the multidisciplinary appointments within the team. We meet weekly. If there are any concerns, if risks are raised or concerns, we meet and we talk amongst ourselves to plan the right care for our patients. We understand their story, we hear it, we see them. And we give them the education, but I also am a big advocate for self-advocacy, knowing yourself, knowing your body, and learning those tools and strategies to, that's not sitting right with me. Ask those questions. Don't just go with what's being told. Yes, we trust our doctors, we trust them, but this isn't sitting right with me. Why is that not? What's the purpose of this? Are there any alternatives? Giving them the confidence to ask those questions. So we go into building their toolbox. So moving on. So this is that role of self-advocacy, and things also, just even things like making sure that you are ready for your appointment, because we all know we turn up to the appointments, they're short. It's taken a while to get there. We couldn't find parking. It was hot. I'm tired. I'm sore. The doctor is sitting in front of you. They're under the pump. There's a waiting room full of people. So being ready for that appointment, and that looks like taking all of your records with you, asking for that second opinion, having a list of all your symptoms, having a list of what's worked for you and what hasn't worked for you. So building those self-advocacy. So as clinicians, we all know the SBAR. So training them and teaching our patients, because we all use that in our practice when we're handing over a patient from one department to the other. We're on the phone to another clinician. We're using that systematic approach to hand over that information. So telling about the situation, the background, action, and then what we want from the results. And then this is our favorite tool, isn't it, Jess? We love this one. This one is a great one. And I know that when I was in the emergency room at the beginning of this year, I was having a freak out. And I messaged Jess and she said, Jill, are you using the brains tool? And I was like, oh God, yes, use your brain, Jill. So it's looking at the benefits of what has been put in front of you. What are the benefits? What's being offered? Are there any risks to that? What are those risks? The alternatives. Do you have any alternatives? But I am going to go back to the benefits. Jess also raised a really good question, not only asking for the benefits of it, but what is the purpose? That's a really great question. What is the purpose of what you've just prescribed me or offering me? Then are there any alternatives? Because I'm interested to know what these alternatives are. The instinct, and this is a big one that I really push with my clients, is that feeling that sits there. You've got something that's been put in front of you and you're like, that's not sitting right with me. Why not? And asking and telling them that that's not sitting right for me. And that's when the alternatives but then also the great one is what happens if we do nothing? Am I forced into this course of treatment? If we do nothing, what's going to happen for me? What's that going to look like for the future? And then not being reluctant or nervous to ask for that second opinion, because you do have a right. A lot of time that second opinion has validated what the first doctor has said, or they come up with something completely different, and then you go back to, okay, what are the benefits of that? What are the risks? What are the alternatives? So it very much is building that self-advocacy for those patients. And then within that toolbox, I tell them that you put together your whole multidisciplinary team as well. So that looks like your GP. So we keep the GP in the forefront of everything that we do. They are important. That is your go-to. Then we've got our nurse, we've got our physio, our dietitian, our counsellor. They're really important to carry that mental load, help us with that mental load. What's happened to us in the past, unpacking that medical mistrust, and then also what the future is going to look like, because there's that anxiety of what the future holds. What does this mean for me? So having that counsellor on board, but we also forget about our pharmacists. They dispense medication to us. They're all part of our multidisciplinary team, and our partners as well, and our support services. So very much advocating for our patients. Yes, that's it.
We love those tools and, use them. When you don't have a brain, use the brains tool is what we say, because it can be so overwhelming in there.